And Katie's going to talk to us about sleep, which, as we were just discussing, is a topic that will be relevant to everyone. And Katie's done quite a bit of work in her previous roles on sleep, so it'd be really interesting to hear an alternative clinical perspective on these things as well. So I'll start recording. Katie, if you want to share your screen, I can hand straight over to you.
I've started recording, Selena.
Oh, you're already ahead of me, Alison.
I'm happy with both.
Right, let me just right. Am I sharing the right one?
Yes, there's a lovely slide there, Katie.
They are nice, aren't they? Thank you. Yeah, I've gone for yet again some interesting slides just because it's Friday afternoon and this might help everyone stay engaged. I realised that the title that went round with this email might have been a guest title, but actually the title is Sleep Management in Chronic Pain, just in case you were wondering. So today is more education than research. So I just wanted to warn everyone about that this is heavily clinical this afternoon. I know these talks do tend to be a bit researchy, but this one is all about the clinical. But if anyone watching this comes up with any lovely research ideas, then I'd be interested to hear. Oh, my slides aren't switching. So just to warn you, most sleep talks I've ever given, someone's fallen asleep or looks like they're nodding off. And I think it's purely by the fact that you're talking about sleep, and sleep loss just might remind you of how tired you might be. So just to warn you, that is quite normal, that I am used to people falling asleep in the session, so I won't be offended. But yeah, just hang in there. So as Selena kindly says, I've got a bit of experience to share when it comes to sleep. So in another life, I started my interest in sleep when I did a PhD in it, and that was looking at the role of sleep in neurorehabilitation. And then from that, I kept up my interest in sleep, where when I started my clinical psychology training, I delivered insomnia treatment groups in a primary care psychology service. And then I carried on after that. For my clinical psychology thesis, I developed an intervention that tailors cognitive behavioural therapy for insomnia to those with chronic health conditions. And then after that, I had a little go at doing a specific sleep group for people with pain after they'd done a pain management programme. And then obviously some of you know 18 months ago I had a baby, so I really now understand the impact of sleep loss more than I ever have. So I think that's reawakened my interest in doing what we can to just improve sleep. And I think the aim of today is just to get sleep back on the agenda for some of you. Just have a think about, you know, we can work on sleep with people with chronic pain. I think sometimes it might feel like it's one of those areas that it will just improve as their pain management improves. But I do think for some of them, they do need a specific piece of work around sleep. So I'm going to talk to you basically about the strategies that we would use in cognitive behavioural therapy for insomnia, but think about how we can apply that for people with pain and other chronic health conditions. It could apply to them as well. So I'm going to focus mainly on insomnia. So when I talk about sleep loss, I'm usually talking about insomnia. So that to diagnose insomnia, all that is you will have difficulties getting to sleep for over half an hour, which for many of us, that's quite standard. You will obviously have poor sleep quality. You will have difficulties staying asleep, so several awakenings throughout the night. And if that occurs 3 times a week for over 3 months, you would fit the criteria for insomnia. If that is over a year, then you would be diagnosed with chronic insomnia. And I've had a little bit of a shock. So if any of you would dance to Faithless Insomnia at school discos like I was, I just couldn't believe that song came out 30 years ago. Can you believe it? Yeah, I know, it's crazy, isn't it? So just have a little bit of think about why we need sleep. Sleep is not a passive process in any way. It serves multiple functions. So first of all, it obviously keeps us nice and alert. We can stay awake. It's very important for our safety, keeping us safe in our environment. It's important for our psychological well-being. So some of you may know, if you've not had a good night's sleep, you're going to be affected the next day. Your mood will be affected, and then more so if it's chronic. It's important for our cognitive functioning as well. So studies will show that if you sleep 6 hours or less, you will likely have some mild cognitive effects of that sleep loss. So for some of us, we might only be getting 6 hours, but apparently, yeah, you may well be suffering a few mild cognitive changes as a result of that level of that lack of sleep. It's important for our health, obviously. If you think about it, when we all get ill, what do we have a drive to do? What do we do mostly is sleep. Studies have shown that, you know, sleep loss can affect our immune system, our response to medications, all sorts of things. So it's really important for our health, important for muscle repair. And interestingly, there's been a bit of an explosion in the neuroplasticity learning side of things with sleep in the past sort of 15 years or so, where we've actually shown that periods of sleep is what facilitates your learning processes. So if you think about all the sensory overload that you get during the day, your brain can't always reconsolidate everything and process everything. So what scientists have shown is that actually sleep is probably the time when your brain does its filing, when it actually commits those memories and experiences and hardwires them into the brain. So they think that sleep is a very key process in that. So again, if we're thinking about our patients with their nervous systems that we want to remold and change their pain experience, neuroplasticity and sleep probably has a key component in that. So sleep issues, as we all know, very common in chronic health conditions, whether that's secondary to the health condition or whether it's comorbid, whether it's something that they had beforehand. Up to 88% of chronic pain patients will have sleep problems, very common in cancer, respiratory conditions and neurological conditions. So specifically to chronic health conditions, they'll experience difficulty getting to sleep and staying asleep because of their symptoms. They will have sensitivity to micro arousals as well. So on an average night, you will have an arousal where you wake up 30 to 40 times a night. Most of us aren't aware of those arousals because it's just literally the brain just becoming slightly awake for a second and going back into sleep again. But for people with chronic health conditions, they're more sensitive to those arousals, so will more likely wake up from them and then become aware of their symptoms. Obviously, things like stiffness, cramps, lying for long periods is going to be problematic for pain patients. They'll have side effects of the medication that will have implications for sleep. And then the cognitive aspects as well, worrying about their health, worrying about sleep loss. And then obviously the increase that we might see in this population of daytime naps, and then fatigue and lack of energy and stuff like that. So medications is an interesting one, really. So I've seen patients that have been on sleep medications for years, and that's probably the case for many of you. But actually, the NICE guidelines say you shouldn't be on it for more than 1 to 2 weeks. Really, sleep medication should be an aid to get you back on track, and then it's something that you wean down from. But lots of people are on it for far too long. And the NICE guidelines recommend cognitive behavioral therapy for insomnia, but then that's a treatment that's not readily available either. So it's a bit of a catch-22. We also know that people on sleep medication, you know, it can help their sleep, but it may also play around with their sleep architecture as well. So we know, for example, that amitriptyline will disrupt their REM cycles. But also with pain relief, you've got the potential for increased sleep need due to the medication, difficulties getting up, too much time in bed if they're woozy from their medication, and then difficulty getting into a sleep routine because of the timing of their medications as well. So the impact of poor sleep on our patients with chronic health conditions will contribute to their ability to function. It can also increase their perception of pain as well. There are a few studies, not many, but a few that I've seen more recently that have looked at PMP outcomes as well, and sleep could well be a factor in how well they do on a program. For those of us that deliver programs, we probably know that those patients that are falling asleep and not engaging, that's going to affect how well they do. It can decrease psychological resilience to coping with the condition as well. So if you're chronically tired all the time, you're going to struggle to cope with your pain over the day. It can affect work, relationships, social life, and people that have had sleep problems for a long time will develop what we call a conditioned response to bedtime and to sleep, where it becomes a thing. It becomes a thing that you expect to sleep poorly. You're preoccupied with sleep. You might start to formulate a lot of safety behaviors, like if I don't do X, Y, Z, then I won't sleep. When you're in bed, you've learned to not sleep. You've learned to lie there and think. You've learned to problem solve. For some people, the nighttime becomes a productive time where you get things done at night when you should be sleeping. So that's another factor that's relevant for our patients. Obviously, fatigue and sleepiness throughout the day, irritability, depression, anxiety. A common one as well is when you don't sleep well, you underestimate how many hours you've slept. So when I used to work in a sleep lab, we'd have the participants come out in the morning and say, God, I didn't sleep a wink all night in that sleep lab. And I'd be thinking, well, from the look of your EEG, I could see you're in slow wave sleep for a lot of the night. So it's very interesting that if you wake up tired, you can end up misinterpreting how long you've slept for, and that can then sort of influence your day, I think, as well. Habituation and coping, unhelpful sleep behaviours, so caffeine, alcohol, sleeping in, all these sorts of things can contribute. And then it will have obviously even more implications for our patients with their cognitive functioning that will already be affected by their pain, but also their safety as well of mobilising, which can be obviously affected by poor sleep and not as coordinated. So just a little bit on the science of sleep. So bear with me here if you're not familiar with the sleep process, but this is really important to know when it comes to treating sleep problems. So the way that sleep works is it's a combination of two different systems. So one is called the homeostatic sleep debt. So what that means is your level of sleep pressure. So basically, however long you've been awake for, your sleep pressure is going to increase. Then when you sleep, your sleep pressure goes down again. You've also got what's called your circadian rhythm, your body clock that you've probably all heard about. So that's our internal clock. That's based in a part of the brain called the suprachiasmatic nucleus. And that is a tiny part of the brain that's like the size of a grain of rice. And that basically creates our timing, and we oscillate over a 24-hour period. So that's something you'll be more aware of when you go on holiday. Obviously, you're going to be sleepy at the wrong times because you experience a clock change. So sleep timing is something that, because it's so intrinsic to us, it's not something that we can change easily. So if you went to go and live in a cave and you had no idea what time it was, you would still roughly sleep at the same times because of that internal body clock. These two things have to work together. So if you can see this graph on the bottom right hand side, in order to create what we call a sleep window, which is the increased likelihood of falling asleep, you need your sleep pressure, this is the S, to be nice and high, and you need it to be timed nicely with your natural circadian rhythm as well. So when those two things work together, ideally you should fall asleep nice and quickly and have a good sleep. But in reality, it doesn't always work like that. And these two systems, your sleep pressure and your body clock, are influenced by environmental factors. So this is where the treatment part's going to come in. We want to work with your sleep pressure and your circadian rhythm. So the sorts of things that obviously are going to influence our sleep pressure and our circadian rhythm are biological. So obviously disease per se, brain damage, medication, treatments, disruption to the central nervous system, neurochemical imbalances that we might have with mental health, and having a sedentary lifestyle. Psychological influences as well on those things might be acute or chronic psychological distress. Also, distress about not sleeping can also perpetuate problem sleeping in itself. That learned sleeplessness that I talked about, that conditioned response to sleep in the bedroom, where you walk in and you instantly become anxious because you know that that's going to be a difficult time at the night. Also, your response to sleep loss is a factor as well, which I'll go on to in a little bit. And also your social environment. This more and more is becoming a problem for our sleep because there's just too much to do, and there's too much you can do in 24 hours. It might depend on your household bedtime as well. What demands you've got. Phones are terrible for sleep. iPads, we take them to bed with us. They are, some of the worst things, as you probably know. I'm going to be talking about that as well. And also changes in life circumstances can influence your sleep as well. If you move house, or you've had a bereavement, or even if you've gone on holiday and you're sleeping in a different bed, all these things can influence your sleep. So back to the science of sleep as well. So this is important to know, is that within when you are asleep, your brain is going through 4 different stages. So this is what we call your sleep architecture. So all 4 of these stages. So it used to be called stage 3 and 4, but now stage 3 and 4 is referred to as just stage 3. So when I say 4 stages, I mean stage 1, 2, 3, and REM sleep. And basically, we will go through one sleep cycle every 90 minutes. So you start with your stage 1 sleep, which is your light sleep. Stage 2 is also your light sleep. So if you can see these things here, these are called spindles and these are called K complexes. And basically these kind of resemble what a slow wave looks like. So when you get into deep sleep, your brain is obviously starting to move on to a bit of slow wave sleep. So all sleep stages are important and they're all restorative in their own way. That's really important because some patients will wake up and say, I've only had light sleep, I've not had any deep sleep, but light sleep is still restorative. And you will cycle through all of these in a 90-minute period. So you go stage 1, stage 2, long time in stage 3 and 4, long time in stage REM, and then you go back to the beginning again. And it is normal to wake up in any of these stages as well. You'll have those, like I said, 30 to 40 brief arousals in a night as well. Now, towards the morning, you start to have less of this slow wave sleep, more of your REM sleep. And that's why if you wake up at 2 o'clock in the morning, you feel dreadful. It's really hard to come to terms with the fact that you've woken up. It takes a while to get going again, but more towards the morning, for some of you anyway, it might feel slightly easier waking up because you've got that experience of knowing you've had a full night's sleep and you're more likely to be in either this light sleep or REM sleep. So because your body needs the slow wave sleep the most, it prioritizes that at the beginning of the night. So that's when you have most of your slow wave sleep. This stuff is really useful to know for patients because I think there's a lot of myths flying around about sleep. So if you've got this good understanding of the sleep mechanisms, that can be really helpful for your treatment. So in terms of the treatments that we have, the cognitive behavioural therapy for insomnia is the big one, really. That's the one that's got a really good evidence base and is semi-widely used. There's some evidence for active mindfulness, and these can be really nice approaches to weave into your cognitive behavioural therapy as well. Obviously, the practical aspects that I'll go into around that CBTI uses are going to be essential if you are using some active mindfulness as well. So we know that CBTI works really well in pain populations. It's just not that widely available. So I'll talk a little bit about that towards the end, about how you might be able to access it. So I think of CBTI as a bit of an onion, really. So the foundations of it is going to be the knowledge, a bit like we have with pain education. We kind of start with that, don't we? So that's really important. So patients understand why we're advising what we're advising, and so they understand what contributes to their sleep problems as well. Building on that, we want to establish a good sleep hygiene routine. So that's a really common strategy that everybody's heard of, but within that, there's quite a few strategies. So we need to get our sleep hygiene in order before we work on the other layers. If you're working on the cognitive aspects of sleep, there's no point doing that until they've cut down their caffeine, for example. So some of these things are really important to start with. Then we need to look at their sleep schedule. That's really important as well. They might be spending too long in bed. They might be going to bed at the unhelpful times. We might have to apply some what we call sleep restriction as well within this section here, just to help again set the scene for these other strategies. So the next layer obviously will be trying to manage stress as best we can during the day, and then work on the cognitive factors implicated in poor sleep, which I'll go into later. And then it's a case of maintenance after this as well. We're not going to fix years of sleep loss overnight. Same as with pain management, this stuff can take quite a long time. The groups that I used to run in the IAP service, it was run over 5 weeks, and you would basically cover each one of these in those 5 weeks, and usually by the end there were some quite significant shifts in their sleep, but obviously you want them to maintain it as well, because like with pain management, we can easily fall back into old habits, can't we? So CBTI per se needs to be delivered by an accredited professional, and it needs to be appropriate for that patient. So the things I'm sharing with you today, by all means, take bits of what you think are going to be helpful clinically, but we can't say that we're doing cognitive behavioural therapy for insomnia because we're not accredited, and it obviously needs to be an appropriate treatment for an appropriate patient. So non-psychologists and non-CBT therapist staff, they absolutely can utilize these strategies, and we do all use them, but the cognitive work, that's the thing that I would say needs to be done by a therapist or psychologist in the context of their psychological formulation, if that makes sense. So we do CBT informed sleep stuff, don't we? You know, but the cognitive stuff, you know, that's something that we'll probably leave to the psychologists and the CBT therapists. So I'm going to go through the strategies now. So apologies if I'm just reeling out loads of stuff at you, but different bits of this will jump out to some of you. So first of all, as I said before, sleep education is really important. Normalising sleep problems. So a third of the UK will fit the criteria for insomnia. So as well as you not sleeping, another 33% of the population will also not be sleeping as well. Really, really common. And we need to obliterate those myths that everyone carries around about sleep. For example, it's okay as long as you're resting to stay in bed. Things like that, you know, it's just part of almost old wives' tales, aren't they, that we all have heard of? Or the other one was, what's it, Margaret Thatcher survived off 4 hours of sleep a night. I don't really know how true that is, but for some people, they might not prioritize their sleep because they might think, well, actually, you only need to sleep a few hours a night. But actually, your basal sleep need will vary from person to person. Some people can function quite fine on 6 hours. Some people need 9. It's very, very variable. Sometimes we can't achieve the amount of sleep that we need as well. It's important to understand sleep mechanisms as well, like I said before, and just establishing the role of thoughts, feelings and behaviours in sleep as well. So it's not just giving you a pill and improving your sleep. We actually need to work on all of these things. So once you've helped your patients get your head around that, we need to move on to the sleep hygiene stuff. So these are modifying those behaviours that promote sleep and reducing those behaviours that can interfere with sleep. So obviously caffeine being a really big one. So caffeine will stay in your system between 6 and 14 hours, depending on the half-life of it. So not everybody knows that. So trying to switch to decaf, and also being aware of what has caffeine in it, because sometimes ready meals will have caffeine in. Chocolate, I'm afraid, has got caffeine in. Some medications have. So it's a really important one, you know, because it's difficult, isn't it? Because patients might use it to stay awake, but it really will be affecting their sleep at night. So I love this picture. This picture here is a picture of my brother's friend in his university days, who has clearly had a little bit too much to drink. And this just shows how powerful alcohol is as a sleeping drug. So he has no idea that they piled all this stuff on top of him and didn't wake up at all. So alcohol obviously is a really good way of getting to sleep, but it is not a good way of staying asleep, and it is not good for treating insomnia, because when your body's trying to break down the alcohol, it's affecting your sleep architecture. You're not getting your REM sleep as much, you're not getting slow wave sleep, you're dehydrated and everything else. So again, that is something to try and knock on the head for our patients if we can, at least 4 to 6 hours before bed, if they want to work on their sleep routine. Smoking obviously is a stimulant. We need to look at that. Eating too close to bedtime, you know, eating chocolate if that's got caffeine in it, things like that we need to look at. And having a bath right before bed is a big one as well, because having a bath will disrupt your circadian rhythm, because the temperature of the bath will raise your body temperature, and it's going to do the opposite of the body starting to wind itself down again. So if you're going to bath, it needs to be at least 2 hours before bed. Sometimes working on your sleep can feel a bit like there's a load of rules that you need to follow, and I can understand with patients it's a bit disappointing, some of the things that they might have to do, but from a biological perspective, these are things that we do really need to work on. As part of sleep hygiene as well is looking at your routine. Now, in my experience, my top tip for sleep is actually protecting that wind down period. That's one of the most effective strategies that I come across. What tends to happen is for a lot of us is we'll have our tea, you know, sort a few things out, but then sit and watch TV, fall asleep a little bit, and then think, oh, actually it's time for bed now. Then we start finishing off the washing up, getting stuff ready for the next day, tidying up that, or I'll just check that email, I'm just going to reply to a few messages. We're actually doing the opposite of winding ourselves down for sleep. We're actually winding ourselves up to be awake, and you might experience almost like a second wind, when really the wind down period is what we should be doing right before bed. So again, this will feel like a load of strict rules, but if we really want to try and improve our sleep routine, protecting that wind down period for at least 60 to 90 minutes before bed can really be effective. If you do all that stuff before your wind down period, get into your pajamas, clean your teeth, have everything done, that wind down time is purely for relaxing. You can watch TV, but the advice is to avoid, obviously, devices. Strictly speaking, it's actually 2 hours before bed, to allow your melatonin levels to rise. So your melatonin is a sleep hormone, and the more light that you're exposed to, that will suppress your melatonin. So we want our melatonin to be nice and high as we approach our sleep window, but if we go on our laptops or iPads, that can disrupt all of that. So that's why ideally, in an ideal world, we want to ban devices during our wind down time, but reading TV is fine as long as you're heading straight to bed after that, you're not doing anything else, and it's protecting that time as well. Rather, so it's just flipping round, you know, all your to-do stuff beforehand. Now, in strict insomnia therapies, they would cut naps completely and say that you can't nap. But I think with our health populations, they may well need a nap to function for the majority of the day. So you can advise healthy napping. So as long as they're not long naps, because if you have a long nap in the afternoon, you remember what I was saying about your sleep pressure building up. If your sleep pressure is high and you have a long nap, that nap's going to be filled with slow wave sleep, and then you're not going to get your slow wave sleep for the night time. So that's why your naps need to be nice and short, and preferably earlier if you are going to nap. So the advice is try and keep your naps to 30 minutes or so, and set an alarm. And also, if you have got a conditioned response to being awake in bed, it's good sleep conditioning to actually take your naps in bed instead. So I'm horrible, aren't I? This isn't very nice when you want to have a nice little snooze in the afternoon on the sofa and you're all nice and warm. But if you are working on your sleep routine, this would be what we would call healthy napping. I don't know if any of you just have that feeling, you know, when you've fallen asleep in the afternoon and you wake up and you feel absolutely rotten. That's because you've woke up in slow wave sleep. So really, we just want to try and have an efficient nap, as we would say, a little bit earlier in the day. And by setting your alarm to 30 minutes, you're not going to go into slow wave sleep then. You're going to hopefully keep that to a little bit of light sleep, which is still restorative. So back to what I was saying before about stage 1 and stage 2 sleep, that is still restorative for your brain and for your function. So sleep inertia is a really good one to talk about with patients as well, because this refers to that period of when you've just woke up and when you're fully alert. No one, well, maybe some of you do, I don't know, but no one really springs out of bed. You have that period where you're kind of groggy. Do you know what I mean? When you've just woke up and you're just sort of coming to terms with waking up, and when you're fully alert, that period is called sleep inertia, and that is completely normal. The brain can't switch from being asleep to being awake that quickly. So sometimes sleep inertia gets mistaken for, oh, I need to press snooze, I need to sleep more. But actually, if you can help your patients understand that sleep inertia is normal, you're going to feel groggy, but that will pass, then they might be more likely to stick to the sleep schedule that you might have set as well. Particularly if you've got someone that tends to sleep in a bit too much, or sleep, you want to try and start to reverse how long they're sleeping in for. Just being aware of that can be very helpful. It's helpful for me, I think, just knowing it's just my sleep inertia. I'll be nice and alert soon. And that, the sleep inertia period will last longer depending on how little sleep you've had, or if you're in slow wave sleep. But just give the brains time to adjust, and you will become your more awake self eventually, usually within, it should be within a few minutes or so. Sleep hygiene, again, stimulus control, this is very much part of sleep hygiene. So this is trying to reverse that conditioned response to the bedroom being an anxious place because you're not going to sleep. So you need to relearn the association between bed and sleep. So you want it to be a welcoming place. Improving bedroom environment can be a really big factor. So if you've got somebody that works in their bedroom, like a student that lives in halls and they've got their work everywhere, or the bedroom's a bit of a mess, just subtly these cues can suggest that this isn't a place to relax in, this isn't a place to sleep. So I've had some patients that have actually treated themselves to a nice set of new bed sheets. They've, you know, tidied their room, redecorated a little bit, and they're trying to almost like baptize their room in a way to say, no, this is going to be a calming place. This is where I'm going to look forward to coming to, and I'm going to aim to have a nice sleep. Clock watching is another one. So really the clock should be turned the other way. We shouldn't be clock watching, because again, that can send really unhelpful signals to the brain of, oh, have I not even fallen asleep yet? It's only 11:30, or I've only got several hours until work. And that can set off a cascade of catastrophic thoughts about, I'm never going to get to sleep. How am I going to cope tomorrow? And it just perpetuates the whole night of just ruminating about the potential impact that the sleep loss is going to have. So not knowing what time it is can be really effective. So there was a study where they told one group of patients that we're not going to set an alarm for you, but you need to be awake by 7, whereas the other group, they had an alarm, so they had a clock. So the group that got told this obviously really had a bad night's sleep, because they're all worried about, how am I going to know when it's 7 o'clock, when am I going to get up? So it's really important to not worry about time. As long as you set an alarm, that's fine, but just don't clock watch all night, because again, it's just going to reinforce the fact that you're not sleeping. A really key thing as well, while I'm on the subject, is to go to bed sleepy. Lots of people go to bed wide awake, or they go to bed at that time because everyone else has, or because they think they should. So again, that conditioned response is reinforced because you go into bed awake. So really, we should be re-looking at someone's sleep schedule and actually thinking, is this the right bedtime? Do you need to go to bed a little bit later? And you can always reverse it back as well. So I'll talk more about another strategy to do that in a minute, but going to bed sleepy is really important. A lot of our patients may go to bed because they're fatigued, which is something different. So fatigue is when you are mentally or physically weary and you have lack of energy, but that doesn't mean you're sleepy. Sleepy means if we put you in a dark room in a bed, you'd go to sleep. So also there's the 15-minute rule. In strict CBTI terms, the 15-minute rule is if you haven't fallen asleep within 15 minutes, you need to get up. Or if you've woken up in the night and you haven't fallen asleep within 15 minutes, you need to get up. So for some pain patients, that's not appropriate to keep getting up and down in the night. We may need to come up with an alternative of their equivalent of a 15-minute rule that means they don't have to get out of bed. But strictly speaking, we need to only use the bed for sleeping. And if we're lying there wide awake ruminating, we should actually be getting up and doing something and going back to bed when we're sleepy again. So just a quick group task, if anyone's up for it, if you've got your calculators on you, it's really helpful when it comes to looking at a patient's sleep schedule to look at what we call their sleep efficiency. So how you calculate that is if you get your sleep time. So if your sleep time was 6 hours, divide it by your total time in bed. So if you have 7 hours in bed, you go to bed at 11 and you get up at 6, but you're only sleeping from 12 till 6. Divide 6 hours by 7, and then if you times that by 100, you'll get a percentage. And for my example here, so 6 hours in bed divided by total time in bed times 100 is 86%. So that's a good sleep efficiency. Anything over 85% is fine. But if someone's sleep efficiency is lower than that, that means they're spending too long in bed, not enough time sleeping in bed, and we may have to work on their sleep schedule or do a strategy called sleep compression. So if that's the case for some of you, if your sleep efficiency is very, very low, come and see me and we can have a chat about your sleep routine if you want. Where's my sleep? Oh, it's not on there. I thought I had a slide about sleep compression. Anyway, sleep compression is kinder to patients than sleep scheduling. Sleep scheduling is quite barbaric, but some insomnia treatment centres will only let you be in bed for the total time that you sleep. So if you've got insomnia and you only sleep 3 hours a night, you're only allowed 3 hours in bed in the strictest of treatments for insomnia. So it's getting quite extreme. We would never do that to our patients. So the alternative is what we call sleep compression, where you identify what the patient's ideal time in bed would be, what their ideal sleep routine would be, and you just work backwards. So if they are not sleeping very long in bed, you might ask them to go to bed 15 minutes later. And then in a week's time, you might ask them to go to bed another 15 minutes later, or you might ask them to get up 15 minutes earlier. That doesn't feel too drastic to experience as a person. And then you kind of aim to compress their sleep time so that they're filling that time in bed with sleep rather than lying there awake. So again, this can be a bit more of an extreme strategy, but for some people who sleep's really bad, then, these are the things that we might need to do. And it's not forever. It's something that, we'll get there eventually. So when it comes to the cognitive work, a lot like the work that we do in cognitive behavioural therapy anyway, is challenging some of the unhelpful beliefs that we might have about sleep and our approach to sleep, managing unhelpful thoughts that we have about sleep, thoughts and worries about our health, and just talking to patients about that, their attempts to control a racing mind in the night, which can perpetuate that, unfortunately. We also might do some work around breaking that link between being in bed and using it to think about the day. So there's some really good strategies to do that. One strategy that I find a lot of patients say is very useful is called putting the day to rest. So some people think you should keep a notepad by your bed and sit and write everything as you wake up in the night. I think that actually perpetuates the whole problem solving and thinking in bed. But actually, if you use the strategy putting the day to rest instead, you just do that at another point. So what we say is that this is not in your wind down time either. So again, this is why it can feel like this treatment can be quite difficult and quite rule based. But if you find a point in the early evening when you might have 10 minutes to yourself, you've not got any disruptions, use that time to write down everything that you think you might be tempted to think about in bed. Now, this is a scientifically tested approach. So this is used by people that treat insomnia and that have researched it quite extensively, and they found that using this strategy, it can actually reduce the likelihood of you using that time in bed that night to go through all that stuff, because you've already done it. Shut the book, it's done, you've processed it, leave it there, then you're less likely to do it at night. You might do some work around, if they are catastrophizing about the impact of sleep, and just remind them, you've coped after many nights of sleep loss already, so why should tonight be any different? Trying to almost reduce that level of care and concern around the fact that they might not sleep, because they probably will cope because they already have, and that paradoxically can actually mean they're more likely to fall asleep. So that strategy is actually called paradoxical intention. Again, that's another well-known cognitive aspect of the CBTI. Winding down, as I mentioned earlier, that again is really useful from a cognitive perspective, psychological. And then there might be other strategies you need to do about general anxiety management before going to bed. Managing a racing mind. So this is where our third wave therapies can be brilliant for this, and we welcome those into this part of the treatment. We think in bed because we can. For some of us, that's the one point in the day when we have no disruptions or distractions. And again, this can become conditioned over time. This is where your mindfulness skills are going to be really useful, not getting caught up in that racing mind, finding a way to manage it, and just reducing the degree to which you use the bedtime to think and problem solve. I've already talked about this paradoxical intention. So you can't force yourself to go to sleep. Sleep is not a switch, it's a process. Give up any concern about being awake. Try, it sounds strange, but try not to care about the fact that you're awake, and that can paradoxically actually mean you're more likely to fall asleep. But this is stuff over time. This isn't something you could do tonight and it will work. This is stuff that obviously a psychologist will open this out, be part of the formulation, but it will take, a good few weeks for this to start to sink in. Response to nighttime awakenings as well. Normalize awakenings. I think we can sometimes wake up and think, oh, I'm awake, why am I awake? But actually remember, you will wake up in the night, it's normal. We need to respond to it effectively rather than react with it. So a bit like the paradoxical intention, it's okay that I've woken up. This is where your mindfulness can be very useful as well. Breathing strategies, things like that. If you are doing stimulus control, that might mean that if you haven't fallen asleep within 15 minutes, you need to get up if you've woken up in the night. Acceptance therapies are also very useful. We're managing sleep problems as well. So again, that's trying to remove this thought that you need to control your sleep, no longer using psychological or behavioral avoidance to cope with sleep problems. With the mindfulness, again, it's present moment focus, non-judgmentally, managing how easily you get hooked on your thoughts and carried away with them. And, you know, ACT and mindfulness, again, have got very good evidence for helping with sleep problems, but it often needs to be weaved in with the stuff that I've already talked about, the background stuff that really is going to affect your circadian rhythm and your sleep pressure. So the whole concoction together can really work beautifully and be very helpful. Just in my experience, you know, just like with pain management, this stuff does require effort. It may require a lot of lifestyle changes. It's not a quick fix. Patients have really got to persevere. With some CBTI approaches, there is a temporary experience of even worse sleep whilst you're getting started with it, but for the greater good. Sticking to the plan, even if your sleep improves. Trying to reduce some of those safety behaviours like alcohol, for example, that might be a difficult one. You know, same with pain management, new habits, motivation for changes, and then the weekends can be a problem. When the weekend always seems to feel like a time when, if you can, is to have a little lie-in. But again, if you're doing some insomnia treatment, it needs to be consistent across all of the week. And again, like I said before, just reminding your patients that years of poor sleep are not going to be undone in just a couple of weeks. It can take quite a while. How can CBTI work in a pain service potentially? Well, I've got a leaflet for one. If anyone's interested in accessing that, I'll happily send it to anyone. So that's basically a summary of a lot of the strategies that I've talked about. It is intended as a guided self-help thing. It's not to replace, it's not to, you can't say they've done CBTI if they've had this leaflet, if that makes sense. If our patients have got some serious sleep issues, when we're talking more about the sleep apneas, the REM sleep disorders like nightmares or things like that, they may need to go to a specialist sleep service. So there is one in Aintree. They don't deal with insomnia, I don't think. These are with the other sleep problems that you can have. You can go to your GP if you've got insomnia. Depends what your GP's got funding for, but some of them have access to these apps. So Sleep Station's one of them. I think Sleepio is another one, where that again is more like a guided self-help process that the patients go through themselves that they may be able to access. But I think at the moment, anything like CBTI, certainly in Liverpool, would be mainly under Talk Liverpool, where the therapist will hopefully have some training in that, and they would be able to support you from a CBT perspective, because a lot of their staff will be CBT trained. Obviously, on a pain management program, thanks to our lovely OTs, we have a session on sleep, which obviously is a lovely introduction to patients to understand the sleep process and get the ball rolling with some strategies. Obviously, they're not here for specific sleep treatment. We've got a whole other host of pain management priority stuff that we need to do. So that's what we offer at the moment. But we get some patients in outpatients, for example. So I've had a couple in psychology where they've wanted to do a piece of work specifically around sleep, where I will apply some of the strategies that I've just talked about. If you are working in a pain service and you have the luxury of spare capacity, potentially it could be an interesting group to pilot or trial potentially. If you think there's patients that complete a PMP, but what always gets reported afterwards is there's still these long-standing sleep issues that might benefit from a CBTI approach, there may well be, you know, appetite for that. So when we trialed it in our pain service, it was done, where I worked in London, it was done after they've done a pain management program, and they actually had obviously got their pain management skills, they were well embedded, they were better regulated over the day, and that was quite a nice foundation to then work on their sleep afterwards. I just did it as a 5-week out, 1 hour session, just like the model I used in IAP services, but you probably could adapt it slightly. So just, yeah, I'm just thinking out loud now, but just thinking about how, how it could work in a pain service. So I'll stop waffling now. That's the end of my presentation. So I hope everybody's still awake, and yeah, happy to take some questions.
Thank you so much, Kate.
Thank you, John.
Yeah, really informative, loads of things to think about. Question from John?
Hi Katie, thank you so much for that. Really good. And obviously we're doing our sleep session. We just started it for the cohort of blue and greens, and then we're going to be rolling out from there. I'm just aware that there can be sometimes some conflicting advice that you come across, from evidence and research and studies. One in particular I'm just wanted to ask you about is this idea of when you are awake and in bed, you should get up and out of bed. Versus being able to reassure yourself, well, I am still in bed, I am still physically resting, maybe using some kind of more productive skills like relaxation or mindfulness skills during that time. So have you got any sort of views on what you think would be the best way forward, or is that a very individual thing?
I think it's an individual thing. I think if you've got someone who clearly has a conditioned response to bed, the bedroom, sleep, they're preoccupied with it, it's a really big thing, I would get quite strict, and I would actually go with the get out of bed and only try and be in bed if you're sleeping, because it might be that they take that strategy as a bit of a safety behavior, that I can stay in bed, it's okay, and I'll try these strategies. But if it's just not working, then yeah, you might have to get them out of bed. But for pain patients that don't use any of that stuff, they haven't got any relaxation that they use at night or mindfulness, then as a first line, that would definitely be appropriate to use. And then if it works, even better. But if it doesn't, then I would probably get more strict, if that makes sense.
Yeah.
We do need to overall reduce their time in bed though. So if they are going to bed at 9 o'clock and they're not falling asleep till midnight, then I'd cut that out, if that makes sense.
Yeah.
And then just use the breathing strategies if they wake up in the night.
Yeah, that's great. And the other thing I just want to ask about is, because this does come up quite a lot, is when people work shift patterns, particularly irregular shift patterns, or they get the rota 2 weeks in advance and that's it. And I've often found it very difficult to kind of work with them around sleep, improving sleep or strategies to improve sleep. So have you got any advice around that?
Not really, no.
Okay.
It's hard, isn't it? Apart from changing jobs, it might be, discreetly, whenever they do sleep, there'll be strategies that they use. In terms of their sleep routine, that would be quite impossible, I guess, wouldn't it?
Yeah.
As long as they're sleeping enough at a different time. So if they do a shift and they're only sleeping a couple of hours and then getting up for the day, I'd worry that their total sleep time per day isn't enough. But if the issue is they're not sleeping when they intend to sleep because of their shifts, that could well be a body clock thing. So it might be they have to sleep in 2 portions. Sometimes shift workers have to do that. Yeah, that is a tricky one.
I think
but
sometimes
like I said,
the environmental factors are quite important there, aren't they? Like making sure you block out all the natural light and things like that.
yes, exactly, because they probably come home and they might do things that wake themselves up again, because they probably got to eat, they probably got to have their dinner at 8 o'clock in the morning.
Yeah.
But it might be you need to think, well, what processes are going on there that are moving you away from sleep or towards sleep? And it might be that's just what they do on those days, and then try and vaguely have a bit of a normal sleep routine on the other days. But yeah, shift workers are really hard, and it apparently can increase your mortality if you do long-term shift work, because of the way that your sleep is, and it just shows how important sleep is.
Just one more thing I want to mention very quickly is that we shouldn't underestimate what patients believe about things as well. I mean, I had a patient recently, we were talking about caffeine, and I said, you're probably aware of the impact of caffeine on sleep. She said, oh, yeah. And I said, and, you know, caffeine can be found in, you know, coffee, chocolate, energy drinks. She said, energy drinks? It's like, yeah. And she didn't realize that how much caffeine she was consuming while she's trying to study, and keep herself awake by studying, by using these energy drinks, and the impact that might have on her sleep. She hadn't connected them. And this is an intelligent lady as well. So
yeah, I know, that's it. They're always surprised, aren't they? So you're right, never underestimate what they don't know.
Yeah. Thanks, Katie.
No worries. Yeah. Oh, Dave, have you got a question?
Yeah, I was, well, a couple probably. So the first one I was interested in is, so I've done a moderate amount of reading around kind of sleep and pain. And one of the things that I came across a few times was kind of, well, chronic conditions generally having a potential impact of not necessarily, or well, the quantity of sleep, but actually more struggling to kind of make that transition from very light stages of sleep into the deeper sleep and kind of REM phases. And there seems to have been, at least when I was last looking at this, which was probably a couple of years ago, a lot of work done looking at pink noise as an attempt, particularly within sleep clinics where you can maybe kind of tie it to those EEG patterns. Are you aware of that? Is that a field that's ongoing, or was that kind of an amazing thing that that turned out to be absolute hokum?
No, do you know what? I've never heard of that. No, I mean, I know with just obviously you'll share this as well, with having a baby, that they talk about alpha music, don't they, that you're supposed to play, that's supposed to help them with their sleep. And I never really thought of it for adults, or certainly a certain frequency it sounds to actually change your sleep architecture, because you'd think if you're listening to something, your brain must have a certain level of arousal. So I don't really know yet how that would work, but I'll have a look at it though, because that's quite interesting. But no, I've never heard of it.
I think they were doing some stuff at St Thomas's and St Guy's. Paul Gringus down there, who's in their sleep lab, was a big part of it. Yeah, my second question was going to be, as the father of a 3-month-old, do you have any cunning tricks to try and convince a 3-month-old child to sleep through the night?
Absolutely not. I'm
I
afraid.
was going to say, if you did, then quit your current job and you'd be a millionaire by the weekend. So
that's the thing. I wouldn't be here if I had that answer. Yeah, I'm afraid not. They just do what they want, I think, at the moment. All I'd say is it's trying to take care of you and your sleep where you can, and they will get there eventually in their own time.
a question less out of scientific interest and more out of sheer desperation.
Yes, absolutely. While you're here, yeah. Nat.
I have no advice for helping helping children to sleep, but this was linking to the point before about all the different types of noise. And my ears pricked up when you guys were talking about that. Just selfishly, whilst we've got the neuroscientists in a meeting with us, I haven't read anything other than pop psychology about that. But my guesswork is it's about trying to activate different parts of the brain with the different noise sounds. Is that right? Because obviously I've done a lot more reading about it from trying to support people concentrate and pay attention with neurodiversity, and that's where they've been looking into all the different types of sounds. So there's like pink sound, but obviously there's like individual preferences based on what is quite soothing for you. So I don't know, just if we've got time, does anybody know anything about that, and are my presumptions correct?
That is a good question. I'm glad to see Chris has got his hand up. That is funny in the pain management.
Great.
Yeah. Well, in the group this morning, one of the patients was telling me that there's a type of music, I've forgotten what it's called now, that apparently helps activate or help self-compassion. He was saying, or something. I need to remember what it was. So yeah, sounds quite relevant. Yeah, sorry, Chris.
Sorry, I was just trying to find the unmute button there. I completely lost it. So I actually don't have a response to that question. I do apologise. I've got a completely different question.
Oh, okay.
Sorry, Chris.
So, yeah, but so I can ask my question if it's helpful at this point. I was interested in what you mentioned earlier about how what was it? You had somebody in a lab and you were measuring their sleep with a EEG, I presume, and they weren't getting or they thought they weren't getting as much sleep as the equipment was saying. And I was wondering if you had any insight into what the role is of how aware people are of how much sleep they're getting or how much time they're getting in the different sleep stages. Because these days, I don't know, I think a lot of people have these Fitbits, don't they, which give you some kind of indication of how much deep sleep you've had. I think they work kind of okay for deep sleep estimation, but for me, not very well for REM sleep estimation. And I'm wondering if you have any insight into people using these things. Do they make people kind of more anxious about how much they're sleeping, or could they actually be helpful? Could it be that people wake up and if they see, oh, I've actually had an hour and a half of deep sleep that I wasn't even aware I had, does it actually put some people's minds at rest? Or could it work both ways depending on the person?
I'm glad you mentioned that. Yeah, I'm not a fan of them telling you your sleep architecture. You cannot say what your sleep architecture is unless you've got electrodes slapped to your head. Obviously, the way that they work is it's basically actigraphy, isn't it? That's what the mechanism is. It's like a little crystal, isn't it, that will oscillate inside, and it basically works on a movement threshold that if you move a certain amount, it knows what sleep stage you're in. And they've got these fancy algorithms that, vaguely accurate, but not massively accurate, that can determine what sleep stage you're in. But I don't think it's helpful, because I've had a lot of patients say, look, I'm not getting enough slow wave sleep. And I was thinking, but how do you know that for sure? Because you will be having some slow wave sleep, but there could be lots of circumstances that might cause you to move, and it might throw off the calculation of the watch, or you might have a Wi-Fi blip or a Bluetooth blip in the night, and it might, not fully record everything. And then I think you become fixated and focused on how much sleep you've had, and it determines your sleep quality, some of them as well. I think mine does. I think mine says your quality of sleep is 70%. What does that mean? And again, I just don't think it's helpful. It might be good as an indicator of what time you've gone to bed and what time you've got up, but it doesn't necessarily tell you how quickly you fell asleep accurately. The accurate ones are the really fancy ones that they use in sleep labs that have got a certain level of sensitivity. I don't know whether Fitbits have the same technology in them. That's the other thing. So there's a few things to be wary of there. So I think if you're working with somebody where they're very fixated on the outputs of these things, I would, get rid of it whilst they're going to work on the sleep.
Yeah, that makes sense. Thanks.
Thank you very much, Katie. Really, really interesting talk. Loads of bits and
You're
bobs
welcome.
we'll take there, and just really nicely presented. So brilliant job. Thank you. I'm just conscious of the time because it's 2 o'clock, and I know people will have sort of clinic patients waiting. So thank you again, and have a nice weekend, everybody.
Thanks, everyone. Have a nice weekend.
Same
Sleep
to you.
well.
Thanks, Katie.
You're
Thanks, Katie.
welcome.
Bye.
Bye.